Now, aneuploidy is when there's the wrong number of chromosomes. So an otherwise healthy individual should have 46 chromosomes in all the cells of their body. And really what most of the research is telling us is that these types of embryos can, as I said, can give us healthy ongoing pregnancies. Some research suggests that the chances of a live birth might be lower than that of a euploid, where other research says that actually the chances are quite similar to that of a euploid. Then that is when there will be what we call biopsied, where we take about 5 cells away from the embryo. Those cells go off for the genetic testing to check for aneuploidy, and the embryo is frozen right after we biopsy. Now, most aneuploidies that we detect don't result in live births with conditions, right? They cause embryos to not implant or to implant and then miscarry. Of course, there are some aneuploidies that are compatible with life, such as Down syndrome, which I think many people may have heard about before.
Welcome, Claire, to the new episode of Let's Talk Embryology. How are you today?
I'm good, thank you. Thanks for having me.
This is going to be a very good episode because Claire is a genetic counselor, and now we are going to listen from her how genetics connects with embryology and specifically IVF treatment. So I'm sure this is going to be a different episode than any of the previous ones. So tell us, Claire, what you do at the clinic.
Okay, so I'm a genetic counselor by training, and I work largely now as a fertility genetic counselor. So my role is really to see patients who are considering genetic screening or genetic testing on their embryos. Patients may be doing this for different reasons. So they may be screening embryos because there's inherited conditions in one or both sides of the family, or they may be screening for chromosome abnormalities because of a history of miscarriages, or maybe because the couple are a little bit older when starting their family. I'd also see patients who consider expanded carrier screening. So they may be doing this because of a family history or just for reassurance. Sometimes patients may do it because they are using donors who've already had carrier screening, and those donors have been found to be carriers. So they want to understand what their risks are if they're going to proceed with that particular donor. I also see patients who have a personal family history of genetic conditions that maybe gets flagged up in the consultation, and the patients want to better understand what this means for them in terms of their reproductive journey or their family planning options.
Wow, that sounds a lot and scientific as well, because I
Yeah.
think there's so many things involved with genetics, all the genetic abnormalities. So how did you get into this field? Was it difficult studying the courses that you did to get at the place that you are right now? How was that experience for you?
Yeah, so it wasn't an easy journey for sure. So just a bit of a background. I originally wanted to do medicine, so I
Hmm.
wanted to be a doctor, but for various reasons, that was quite a difficult path to follow. I've always had this love of science and working with people. And when I wasn't able to do medicine, interestingly, along the way of my studies, I came across this career in genetic counseling, and I thought, well, that's brilliant. That can bridge the gap between the science and the person, the patient on the other side. And so I started to look into that. And I was already studying. So sort of just figured out the next path to get into that field. So my background in terms of what I studied and how I got to be a genetic counselor. So when I wasn't able to get into medicine, I started studying a BSc and I majored in genetics and human physiology. Genetics has always been a really fascinating field, and I think, the general public agree with that as well. And then after my BSc, I did a Bachelor of Health Science honors in human genetics. And then I did a master's degree, so an MSc Med, which focuses on genetic counseling. So genetic counseling is actually a degree. I did that in South Africa, but obviously these degrees are offered in various countries around the world.
Wow, and was it difficult for you just to study because there's a lot of genetics involved and there's a lot of science involved? Were the courses difficult?
I've always been a bit of a nerd, so I do love science, maths,
Yeah.
those sorts of subjects. So for me, it wasn't, I'm not saying it was all smooth sailing and all easy, but for me, I enjoyed it and I did pretty well at those subjects. But getting into genetic counseling was very competitive. I had to do lots of interviews. I had to write essays. There were various things that we had to do to prove ourselves. So that was quite challenging, but I did end up getting in the end. Studying genetic counseling was tough. Sure, there's the science, which, it's always come quite naturally to me, but there's the counseling, the psychology aspect as well, which maybe didn't come so naturally. So that was something that I had to learn. I didn't have any training in psychology or counseling. A little bit of that is done in the course, but not huge amounts. So something that you kind of have to learn as you go. And that I found was the most challenging part. But interestingly, although I found that the most challenging part during my studies, I find that the most rewarding part now, that part of my job.
Right. That's a very interesting point that you just raised the psychology as well. It's just not about science, but also understanding the psychology behind, especially when you are delivering results to patients. I think
Yeah,
that's an important skill to have, and not just the knowledge. Yeah, we'll come back.
absolutely.
We'll come to that part later. But
Mhm,
so when you completed your courses and
mhm,
when you were trying to get trained in the actual clinic, did you
mhm.
also need any separate registration as a genetic counselor, or how does that work?
Yeah, so I studied in South Africa, as I said, that's where I completed my master's degree. Our degree was a combination of coursework and practical clinic experience. Once that was completed, which is a 3-year program, you have to do a year's internship where it's worked experience at an academic or public hospital supervised by qualified genetic counselors and consultants. So that's what we had to do. And then once that was done, submit a portfolio, which covered case reports, sort of reflections, essays, case logs, etc. That is reviewed by the Health Professionals Council of South Africa, obviously where I was. And then you're awarded registration if you meet all the requirements. So I am registered in South Africa with the Health Professionals Council of South Africa. There's obviously registration boards in the UK as well, which I'm not currently registered with because I still maintain my registration back home, but that is something that I'll be working towards in the future.
Wow, that's so fascinating. Still, some of the journey to go ahead. Not there yet. You have still
No.
plans on your mind. Yeah,
Yeah.
that's good. That's good. So coming back to now the clinical part,
Mhm.
what does your day look like in the clinic?
So I work 4 days a week. 2 of my days are dedicated to admin. So, just following up on certain patient cases, writing clinical letters, delivering any results that have come through, reviewing any cases with doctors. I run an MDT once a month to review complex cases. I'm also involved in writing, SOPs and creating leaflets and things for the clinic. We've recently created an educational video which covers PGT-A, which we'll speak a little bit more, I'm sure, in the upcoming minutes or so. And that's just to help streamline the work processes within the clinic. So that's what I kind of do on my quote unquote admin days. In my clinic days, which is the other 2 days of the week, I see patients virtually, so I don't do any face-to-face consultations. For now, I'm largely seeing patients considering PGT-A testing before they go for the testing to provide informed consent. But then I may also see patients, as I said, that are wanting to discuss inherited conditions, carrier screening, etc. So I see 4 patients currently in my clinic, in one clinic. Our consultations are quite long, an hour to an hour and a half, so they're quite involved. And there's a lot of admin and paperwork follow up from that. So that does take up most of my day.
Right, makes sense. Yeah. You just mentioned something about PGT-A. Do you mind
Mhm.
explaining what the PGT-A is?
Yes, so PGT-A, what it stands for,
Hmm.
we use this acronym a lot, but I suppose, we don't all know what it stands for, but it stands for pre-implantation. So that means, before we even get pregnant, essentially on an embryo, we're doing a genetic test and we're doing a genetic test to screen for aneuploidy. Now, aneuploidy is when there's the wrong number of chromosomes. So our chromosomes contain our DNA, which is packaged up. And the DNA is the instruction, the code book for how the body needs to develop and work. So an otherwise healthy individual should have 46 chromosomes in all the cells of their body. We know that sometimes during human conception, so in embryos, we may have the wrong number of chromosomes, too few or too many. That contributes to things like failed implantation, miscarriage, maybe sometimes ongoing pregnancies where babies got associated health problems. So PGT-A screens embryos to check whether they have the right or the wrong number of chromosomes so that we know which embryos we want to put back and which embryos we don't want to transfer back to a couple.
Right, right. And what day does this happen? As in the terms of embryo development, which day does this testing take place?
Yeah, so the day of the egg collection is day 0, and the next day is day 1 when check for fertilization, and then around day 5, 6, sometimes even 7, when embryos have reached the blastocyst stage, they're assessed by the embryology team to see if they're good quality blastocysts. If so, then that is when they will be what we call biopsied, where we take about 5 cells away from the embryo. Those cells go off for the genetic testing to check for aneuploidy, and the embryo is frozen right after we biopsy. So it's between day 5 and 7 when the testing usually takes place.
Right, right. And then once the results are back, then you can identify which of the embryos are chromosomally normal and then which of them are abnormal. Is that what the results tell, or are there any additional comments that the results can reveal?
Yeah, that's a good question. So it isn't always necessarily so clear cut. Sort of conventionally in most labs and clinics, or most PGT-A labs will report PGT-A results as euploid. That means that all the cells that we've analyzed have the correct number of chromosomes. That's usually an embryo that is suitable for transfer. And the lab might call an embryo aneuploid. So that's when we have the incorrect number of chromosomes in all the cells that we've analyzed. That's usually a highly accurate result. And embryos with the wrong number of chromosomes don't give us healthy ongoing pregnancy. So those embryos don't usually get transferred back. Sometimes we may get somewhere in the middle, is what we call mosaic results. So that's where the biopsied cells have a mix of chromosomally normal and chromosomally abnormal cells. And while that may sound a bit concerning, interestingly, lots of research has showed that that's not a very accurate result in terms of telling us about what's happening in the entire embryo. And a lot of research has also shown that those types of embryos, when transferred back into the womb, have a very good chance of giving us a baby and a very good chance of giving us a healthy baby, a low chance of having, a baby with a chromosome disorder. So interesting data that's coming from the research. And that's how most labs will report it. There is a handful of labs, or at least one lab that we know of, that reports slightly differently. So they'll report a negative result. That means that no clinically significant chromosome abnormality was detected in the cells, or they may report as positive. That means that there was a clinically significant abnormality detected in the cells, and usually we would transfer back negative embryos. We would not transfer back positive embryos.
Right. I imagine even when you say mosaic embryo, it's not that easy to classify whether that embryo is still suitable for transfer, or are all the mosaic embryos transferred irrespective of any other risk assessment? Or do you do any risk assessment?
Yeah, so the data is emerging, the evidence, the guidelines are changing the more and more we're learning. Initially when mosaicism was detected, a lot of clinics, doctors, patients were worried to transfer those types of embryos because they thought there was a high chance we'd have a chromosomally abnormal pregnancy. But as I said, there's a lot of research that has happened since mosaicism was able to be detected. And really what most of the research is telling us is that these types of embryos can, as I said, can give us healthy ongoing pregnancies. Some research suggests that the chances of a live birth might be lower than that of a euploid, where other research says that actually the chances are quite similar to that of a euploid. Regardless, I think the main concern is that we don't just want a live birth, we want a healthy live birth. So what's consensus through the literature is that there's a very low chance that a mosaic embryo would give you an ongoing pregnancy with a baby that's got a chromosome disorder. Probably not any significantly higher than sort of untested embryos, for example. So that's quite reassuring data. And based off of that, we really follow the evidence. Based off of that, we encourage people to consider transferring mosaic embryos. Of course, if there's any euploid embryos, those would be our priority. Those are a bit more straightforward. But we certainly don't want to disregard any mosaic embryos or waste an opportunity to use an embryo that could have been a baby for a couple. We do currently recommend people have genetic counseling just to talk through what it means. What does the data tell us? Are there any risks that we need to think about? If people are worried, what are the extra tests they may be able to do if they get pregnant from that embryo, etc. So it's really just to help guide people to make informed decisions and feel comfortable about their decision. But at the end of the day, as a clinic, we're quite comfortable with that. I know that that's not standard practice across all clinics, and some clinics still do not transfer these types of embryos. But really, we're going with what the research and the evidence is telling us.
Right, right. There's still a lot to think, even if it's a mosaic embryo. I think there's a lot behind the scenes which
Yeah,
happens before the transfer actually takes place, right?
absolutely. Yeah.
So the third type of embryo that you said abnormal, which has extra set of genetic material, I think that's what it means by abnormal.
The aneuploid.
Sorry, yeah, aneuploid, yeah,
Yes. So
right.
aneuploid means that all the cells that we've biopsied from the embryo had some sort of chromosome abnormality within them. Now, interestingly, you mentioned that question because there's different types of chromosome and abnormalities that we can get. So we get what we call whole chromosome aneuploidies and segmental aneuploidies. So whole chromosome abnormalities is when there's an entire copy of a chromosome that is either missing or extra. And a segmental aneuploidy is when there's a segment, as the name implies, a segment, a piece of a chromosome that is missing or extra rather than the entire chromosome. And why we mention these two different types of aneuploidies is that actually they mean different things. So whole chromosome aneuploidies, there's a lot of data to show that that's usually a very accurate result, and that's likely to be in all the cells of the embryo, that abnormality that we detected. And so again, embryos with the wrong number of chromosomes don't give us healthy ongoing pregnancies. So those embryos we do not consider for transfer. But segmental aneuploidies, there's been some very recent data. Although it's quite limited data, but it is interesting to tell us that segmental aneuploidies may not be as accurate as whole chromosome aneuploidies in terms of telling us about what's in the cells that will form the fetus. Because for PGT-A, we biopsy the outer cells, which is what is going to form the placenta, hoping that tells us about the whole embryo. And most of the time it does, but not always. So segmental aneuploidies, again, very limited, but recent data showed us that maybe not so accurate. And interestingly, of the small number of studies that have transferred those types of embryos back, there's been around a 25% on average live birth rate. So,
Oh,
so
wow. Okay.
those types of embryos we're starting to think of a little bit differently. And it's something we're keeping in mind, again, for couples that have no other options. It would be accompanied by careful genetic counseling, risk assessment, before we would consider using those types of embryos.
Right. So when you test the embryos, are there any genetical conditions that you can detect through the testing?
Well, through PGT-A testing, which is a very specific type of test, we can only detect aneuploidy, so whether there's the wrong number of chromosomes. Now, most aneuploidies that we detect don't result in live births with conditions, right? They cause embryos to not implant or to implant and then miscarry. That's what most aneuploidies would cause. Of course, there are some aneuploidies that are compatible with life, such as Down syndrome, which I think many people may have heard about before. That's where there's an extra copy of chromosome 21. And there's other conditions chromosome conditions that are compatible with life, such as Edwards syndrome, trisomy 18, where there's an extra copy of chromosome 18, or Patau syndrome, which is trisomy 13, where there's an extra copy of chromosome 13. We also get sex chromosome abnormalities, where we've got differences with the X's or the Y's chromosomes. So PGT-A can detect those. Of course, if one doesn't have PGT-A, those sorts of conditions are generally screened for within pregnancy at around 12 weeks. But PGT-A cannot screen for any inherited conditions or any conditions that are caused by single genes or other genetic mechanisms. If there is a condition in the family or in the couple, a different type of test is needed for that. That's called PGT-M, where we screen for single gene conditions that can be passed on from one or both of the intended parents.
Right, right. So PGT-A is for detecting the set of chromosome or multiple chromosomes, but PGT-M is for a single gene, right?
Exactly. The M stands for monogenic, which just
Okay,
means when one gene is
right,
implicated in causing a condition.
right. I've also heard something called PGT-SR. Can you also tell us what
Yes.
exactly that is?
Yes, so that's a similar test to PGT-A. And what it stands for is pre-implantation genetic testing for structural rearrangements. So what that means is that sometimes, it's not common, but sometimes one or both members of the couple may carry a structural chromosome rearrangement. So that's when the structure of one or more of their chromosomes has been altered. The most common rearrangement that we may see in couples is a translocation. So that's when essentially two pieces of two different chromosomes, usually end pieces, have broken off and switched places. Now, for the person that carries that translocation, that usually doesn't cause any disability or any sort of significant health concerns because all their genetic material is still there. Their genetic material is balanced. But when they go on to try and try and make a baby or start a family, they only pass on half of their genetic material as the other intended parent passes on the other half. So when pieces of chromosomes have moved around, you can certainly still have healthy pregnancies and healthy babies, but it increases the chance that your egg or your sperm, depending on which side it comes from, may have unbalanced genetic material because
Right,
those pieces have moved around. So PGT-SR, exactly the same as we do PGT-A, where we biopsy the embryo on day 5 to 7, we look at the cells to see, does the embryo have balanced genetic material or unbalanced genetic material in relation to that translocation? Um, yeah,
right, right. That's so much to consider. I'm sure your consultation must be, like you said, 1 hour long because there's so much to discuss. And I think by
absolutely.
every patient, it keeps on varying, the factors keeps on varying. So you have to take all those factors into account and then see what's best for the patient. But
Absolutely.
since you have so many things that you can detect through embryos, shouldn't PGT-A be recommended for everyone? Because in my experience, not everyone does PGT-A testing. But shouldn't that be the case that everyone should do PGT-A because you get the right information that you want and you minimize the risk essentially.
Yeah, that's a really good question. And I think you will find certain groups who will argue for that and other groups that may argue against that. The reality is that, any couple is at risk of producing a chromosomally abnormal embryo, but it's about the probabilities of that happening and weighing that up against the risks of the testing, because the PGT-A testing, as you've heard, we take some cells away from the embryo, so it is invasive. So by definition of the test, it can cause damage to potentially an otherwise good embryo. So it's not without its own risks. So, if you are a young couple where the background risk of aneuploidy is really, really low, and we do PGT-A, and in the small chance your embryo is damaged, there's a much higher chance we've damaged an otherwise healthy embryo. So you've got to weigh that up. Additionally, some couples, for example, if the female has low ovarian reserve, so we don't expect maybe to get a large number of eggs and therefore a large number of embryos, we've got to factor that in as well, because not all embryos are suitable for biopsy. Embryos have to be really well developed, good quality blastocysts in order to be safe to biopsy, whereas they don't necessarily need to be the same quality to be considered just for a fresh transfer to be put back straight away. So if a couple only produces maybe one lesser quality embryo, and our goal was to PGT-A test, we wouldn't be able to PGT-A test. We wouldn't be able to keep that embryo. So there'd be no embryo from that cycle. But if
Right.
the couple had actually just said, okay, well, let's just do a fresh transfer because I'm not going to get a large number of embryos, then again, the embryo wasn't suitable for biopsy, but it doesn't matter because we're putting it back fresh. And then we're just letting, sort of nature take its course and see what happens. And sure, we know that lesser quality embryos have lower success rates, but they don't have 0% success rates. So in that scenario, we've given the opportunity for that embryo potentially to be successful. Whereas if we tried for the testing, we would have had no embryo in the end to do anything with. So there's certain nuances. And I think that's why, where we work, we're very careful about who has this testing. We make sure that it's suited based on your fertility and personal history.
Right. There's so much to think, isn't it? All about risk assessment,
Yep.
who genetic te testing is recommended for. It sounds very optimistic that everyone should do it, but there are still so many factors that you have to consider, even though it reduces the risk in a certain way by filtering out the genetically normal embryos, but still on the other hand, by reducing those risks, you have these other risks that take place. And so,
Absolutely.
yeah, I'm sure there's so much to think by patient basis. Does it ever happen that when you test the embryos, when you get the result, sometimes any one of the embryo or more than one of the embryo shows no result at all?
Yeah, that is one of the possible outcomes. It's not very common. I think it happens roughly maybe 2 to 5% of the time. We may get no results. That can happen for different reasons. The cells may have not had any DNA inside of them, so we couldn't do the test. The DNA with it, the cells may have had some DNA, but it was poor quality DNA, so we weren't able to amplify it, make copies to be able to do the test, or it was poor quality, so the data from that DNA wasn't good. Um, we essentially treat that as an embryo that didn't have a genetic test, and then we give patients different options. They can leave it as is and transfer essentially without a result, or they can rebiopsy the embryo. Of course, there's more risk because we've got to now unfreeze the embryo,
Right,
biopsy a second
right,
time, and freeze again.
right. So, like you said, it doesn't happen a lot. So maybe not a lot of patients would have to thaw the embryo and do the testing again. Yeah.
Yeah.